Hi, I am Dr. Saurabh. Today we will discuss two important hemodynamic artifacts in the cath lab, which is pressure damping and ventricularization. These two terms are often used interchangeably. However, they are hemodynamically distinct. Both indicate possible flow limitation due to catheter position and warn us about potential vessel injury if contrast is injected. Before discussing these artifacts, let us first understand the basics of pressure recording. I will try to keep this complex topic as simple as possible. Each ventricular contraction generates a pulse wave that travels through the arterial system. This has a rapid upstroke, a downstroke, and a diacritic notch. The waveform is recorded through a fluid-filled catheter transducer system which acts as a liquid microphone listening to the heartbeat. The pressure waveform is made up of multiple harmonic frequencies. The catheter transducer system must have a natural frequency high enough to accurately reproduce these harmonics, otherwise waveform distortion occurs. Coronary blood flow is more complex than simply saying it occurs during diastole. A useful analogy is a sponge. When squeezed, water is pushed out. When released, water is drawn back in. A similar process occurs within the coronary circulation. Six waves contribute to coronary blood flow during the cardiac cycle. The early backward traveling pushing wave occurs with onset of systole as microvascular is compressed because of powerful ventricular muscle contraction. A dominant forward traveling pushing wave occurs as the blood is injected into aorta. A late backward traveling pushing wave is caused by continued compression and wave reflections from bifurcation of the coronary artery. A forward traveling suction wave occurs as the ventricular contraction slows down, and a dominant backward traveling suction wave occurs during myocardial relaxation and is responsible for peak coronary flow in diastole. This is where maximum coronary blood flow occurs. The final wave is the late forward traveling pushing wave, which occurs later in the cardiac cycle. Let us first understand pressure waveform distortion. An underdamped system behaves like a car with broken shock absorbers. It overreacts to the heartbeat and produces exaggerated, spiky waveform, which are often called catheter fling. An overdamped system does the opposite. Waveform becomes smooth and loses important details, which we will be seeing on next or further slides. Air bubbles in the catheter transducer system are a common cause of underdamping and should be removed. Now let us discuss coronary pressure damping. Normally, the catheter sits at the coronary ostium while still allowing some blood flow around it. Pressure damping occurs when catheter is almost as large as the coronary ostium or when catheter tip is pressed against the vessel wall, like here. In both of these situations, flow becomes restricted and pressure waveform is distorted. In the cath lab, what we commonly call damping is actually overdamping. It produces falsely low systolic and falsely high diastolic pressure recordings. Waveform develops a narrow pulse pressure with delayed upstroke and downstroke. Common causes are atherosclerotic ostial stenosis and catheter-induced coronary spasm. To understand it better, imagine the catheter is a drinking straw full of water. If you press the tip of the straw against the wall of the cup, the water inside gets trapped and cannot wiggle back and forth. As the fluid is physically stuck, the system becomes sluggish. It goes deaf to the high speed detailed vibrations of the heartbeat. As it cannot feel the fine details anymore, the waveform on the monitor loses its sharp points, it becomes flattened, delayed, and unnaturally smooth, which we call damping. Ventricularization is less severe form of damping. It occurs when the catheter tip becomes wedged within an ostial stenosis or when coronary lumen closely matches the catheter diameter. The waveform develops a large pulse pressure with marked fall in the diastolic pressure. Diacritic notch disappears and a presystolic positive deflection called A wave appears due to atrial contraction. Here both systolic and diastolic flow are impaired, but substantial systolic flow is preserved. So it mainly affects the diastole. Ventricularization is mainly caused by catheter wedging. Traditionally, it was thought that ventricularized waveform represent left ventricular pressure. However, studies by Dr. Morton Cohn showed that waveform is not identical to true left ventricular pressure. This suggests that ventricularization has a different mechanism, which we will discuss next. Ventricularization is actually a hybrid between coronary arterial pressure and coronary wedge pressure. When the left ventricle contracts, it compresses the intramyocardial arterioles. As we have seen in the previous slide, it generates a ventricular-like pressure wave that is transmitted backward through the coronary circulation. The catheter records this mixed signal, producing characteristic ventricularized waveform. There are important differences between right and left coronary system. The RCA receives substantial flow both during systole and diastole because the right ventricle is a low pressure chamber. As a result, pressure damping is common in the RCA, whereas ventricularization is uncommon. As we saw previously, ventricularization is predominantly diastolic. As the left ventricle generates greater myocardial compression, left coronary flow is predominantly diastolic. Therefore, ventricularization is seen more commonly in left main coronary artery. Both of these things are commonly seen in cath lab. The pressure damps on engaging RCA, whereas it can become ventricularized on engaging left main coronary. The most important message is that no further contrast injection should be made when damping or ventricularization is present. Continuing to inject may cause ventricular fibrillation, dissection of the coronary artery, or thrombosis. Catheter should be withdrawn and repositioned. Alternatively, a gentle injection during withdrawal or a non-selective aortic cusp injection may be performed safely. Thank you.